Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Shivaraj Afzalpurkar, gastroenterologist at Naniappa Hospital, Davangere, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
I'm Dr. Shivaraj Afzalpurkar, consultant gastroenterologist, endoscopist and liver specialist in Naniappa Hospitals, Davangere.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
IBS or irritable bowel syndrome, it's a chronic gut condition where a patient complains of abdominal discomfort or abdominal pain with associated bowel movements abnormality like constipation, diarrhea, or alternate constipation or diarrhea. And this abnormal bowel movements is usually associated or linked with the abdominal pain. So this is the simplest term I can explain what IBS is.
How does modern lifestyle food habits, stress, and sleep contribute to IBS?
Modern lifestyles like food habits or disturbed sleep or increased stress definitely linked to IBS. This is because of disturbed gut-brain axis. So gut-brain axis plays an important role in our digestion. So if it is affected, definitely our digestive system will be affected. So this will cause altered bowel habits, increased bloating or abdominal cramps, and in fact lead to altered gut microbiota. So in this way, the modern lifestyle plays a very important role in controlling the symptoms of IBS.
What are the top 3 red flags that make you suspect IBS in a patient?
So the most important symptoms in IBS would be, one is pain abdomen or abdominal discomfort. A second thing would be change in bowel habits. Either it could be constipation, it could be diarrhea, or some periods of constipation and diarrhea alternately. And the third thing would be bloating or excessive gas or excessive postprandial fullness or discomfort would be the most common symptom where the patient with IBS complains.
What simple screening questions can a consulting physician ask to suspect IBS?
So any patient where I'm suspecting IBS, I would ask in last 3 months, how frequently you're getting pain abdomen and how frequently is your bowel disturbed. Are you suffering from constipation or suffering from diarrhea, or is there any alternate diarrhea with constipation? Whether this altered bowel habits like constipation and diarrhea is linked with the pain abdomen. Sometimes people complain of worsening of pain after passing stool. Some people complain of relief of symptoms of abdominal pain, bloating, or cramps after passing stools. This is the very important screening question I would ask. And the other thing would be the stress levels. Any recent change in the sleep pattern, recent change in the stress levels, recent change in the food habits, like eating more of a spicy, oily food or outside food or more of muscle items. These questions I would preferably ask in a patient who is suffering from IBS. And before, when I suspect IBS, I would rule out there is something called as IBD, that is inflammatory bowel disease. Some alarm symptoms I would ask, like, is this pain abdomen or altered bowel habits is associated with any alarm signs like weight loss, that is significant weight loss of more than 5 to 10% in the last 3 to 6 months, or any blood mixed stools or black colored stools, or blood vomiting or blood stained vomitus, or any symptoms like decreased appetite or recent change in bowel habits. I would definitely ask before I would suspect IBS.
What are some common mistakes in diagnosing IBS at the primary care level?
Fine. Now, in any patient with pain abdomen or bloating, you should not suspect IBS. First we have to rule out any organic diseases. Organic disease in the sense, in elderly patient we have to rule out malignancies. In young adults we have to rule out IBD, that is inflammatory bowel disease. And sometimes a simple gastritis or simple H. pylori induced gastritis or dyspepsia, or sometimes GRD, that is gastroesophageal reflux disease, would present similar way to IBS. So we have to first rule out those things and then we have to suspect IBS. This is the common mistake where practitioners get confused between IBS and IBD. Both are completely different spectrum. IBS is a functional bowel disease, that is irritable bowel syndrome, and IBD is an organic disease which is of two types again, ulcerative colitis and Crohn's disease.
Are there any warning signs where a physician should immediately refer to a gastroenterologist?
Fine. As I've mentioned previously, whenever you're suspecting an IBS, we have to ask for the alarm signs. Or if the patient is already diagnosed with IBS, we have to ask repeatedly the alarm symptoms. Like, in a patient who is already been labeled as IBS, whether he is losing any significant weight, or if the patient is having any, blood mixed stools or black color stools, or if the patient is having any other symptoms like, fever, decreased appetite, or the symptoms have changed from the usual complaints what the patient used to complain. So these are the important warning signs. I would ask the physician to notice it and then refer immediately to a gastroenterologist, so that it will be appropriately investigated in the form of endoscopy or colonoscopy to rule out any organic disease or malignancies. And then if it is negative, then we can continue the treatment in the form of IBS.
Once IBS is diagnosed, what is your first line approach to management?
So once we diagnose IBS, the first and foremost important thing is the diet. Diet, what we call as low FODMAP diet, food containing oligosaccharides, disaccharides, monosaccharides, and polyols. So we would advise patients to have low FODMAP diet. And the second thing is reducing the stress levels. If the patient is already having some stress, kind of whether it is a professional, personal stress, or if there is any anxiety, depression kind of thing, we have to treat it adequately. I mean, in the form of medicines or counseling. And the third thing would be to treat the symptoms. I mean, symptoms, if the patient has constipation, we have to give laxatives. If the patient has diarrhea, we have to give some antispasmodics. Usually the pain abdomen will be the associated features along with constipation and diarrhea. So we have to treat pain abdomen also with good antispasmodics. And then if the symptoms are still persistent, then we can give some anxiolytics or antidepressants if there is no relief of symptoms.
What's the role of diet? Do you recommend low FODMAP, fiber modification, or any particular dietary pattern?
So low FODMAP diet definitely plays a very important role. It is the proven diet which helps in patients with IBS. So as I've mentioned, low FODMAP is food containing oligosaccharides, disaccharides, monosaccharides, and polyols. The common foods which contain high FODMAP are: one is apple, peach, watermelon, onion, garlic, or sweet corn, mushrooms, or sometimes kidney beans or cashews, lentils, or some food containing wheat or food containing dairy products. So these are the common foods which contain high FODMAP. So initially, for at least first 2 to 6 weeks after the diagnosis of IBS, we have to avoid this foods containing high FODMAP diet, and then we can slowly introduce one by one till a balanced diet is reached.
How do you deal with recurrent or relapsing IBS cases that come back after initial improvement?
So whenever a patient with IBS, when he suddenly comes back with the similar symptoms where initially there was remission of those symptoms and then again he comes back with the same symptoms, I would like to ask a detailed history, whether in recent times whether there was any change in the dietary habits, whether there was any change in the stress levels, whether the patient is having any disturbed sleep. So if it is yes, then I would first like to correct that thing. I mean, the patient they have to again go back to their normal, low FODMAP diet and reduce their stress level. They should have adequate sleep. And then we have to treat any, particularly if the patient is having any, commonly in India, helminthic infections. If we are suspecting any helminthic infections, we have to treat it. Commonly food poisoning. If we are suspecting anything like that, we have to treat it. And then if there are any alarm symptoms, if the patient is developing, then we have to rule out organic diseases like IBD and malignancies, and then continue with the standard treatment, like managing the pain with antispasmodics, managing the constipation with laxatives, and managing diarrhea with some anti-motility drugs. In this way, we can again control the symptoms of IBS if there is any recurrence.
How can physicians and gastroenterologists collaborate better for early IBS diagnosis?
Physician will definitely play a very important role in diagnosis and treatment of IBS, because they are the primary contact for the patients if they have these common symptoms like pain abdomen or altered bowel habits. So if any patients will present this kind of symptoms, that is pain abdomen associated with change in bowel habits, that change in bowel habits is linked to this pain abdomen. That is, either the change in bowel habits will cause worsening of the symptoms or improvement in the symptoms. In those situations, we have to do a common basic test like we have to rule out anemia, we have to rule out any hypothyroidism or hyperthyroidism, we have to rule out any malignancies, like a basic endoscopy or colonoscopy should be done. We have so that IBD, that is inflammatory bowel disease, is ruled out. This can be usually done by a gastroenterologist, where he does a endoscopy, colonoscopy, and then if there is any suspicion, he takes a biopsy and then rule out inflammatory bowel disease. And once all the organic diseases are ruled out, then we have to label it as IBS, and then IBS can be treated by a physician or a gastroenterologist. Thank you.
Thank you, Doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.